Eric Alexanderson, junto con la doctora Aloha Meave, Cardiocademic. Cardiocademic es una línea hecha para mantener la educación médica continua, periódica de todos nuestros participantes. Estamos muy contentos, estamos en una época muy compleja en estos tiempos y estamos muy contentos de compartir este webinar durante todo este mes, que va a tocar predominantemente el tema de imagen cardiovascular, y para eso hemos invitado a muchos expertos nacionales e internacionales para que vengan a compartirnos sus experiencias. Espero que esta oportunidad académica sea de mucha utilidad para ustedes. Vamos a estar compartiendo una encuesta al final de la sesión para saber su opinión de esta primera sesión, de este primer simposio. Tendremos 8 durante todo el mes, martes y jueves de 4 a 5 de la tarde. Cada presentador tendrá 25 minutos de presentación y 5 minutos para poder hacer preguntas. Las pueden hacer por el chat que tienen y las podemos nosotros resumir y hacérselas a la doctora, a las doctores que estarán el día de hoy con nosotros. Paso sin más preámbulo y bienvenidos todos y gracias por estar conectados con nosotros. A la información a la doctora Aloha Meave para presentar a nuestra primera ponente.
Hola, ¿qué tal? Buen día a todos. Soy la doctora Aloha Meave y bueno, es un gusto para mí el que podemos dar inicio a esta serie de webinars, pues con este gran personaje. Para mí, la doctora Dipti Chaporia, vicepresidenta del American College of Cardiology, muy conocida por todos y bueno, en particular para mí una persona muy importante porque es una mentora, una persona muy importante en lo que se refiere a mujeres en medicina. Entonces, dear Dipti, we are so happy you are here with all of us sharing this lecture. And I was saying that in behalf of Cardio Academic, we want to thank you. And for me, especially for me, it's so important to have you here because for me, you are such big example and a mentor talking about the women in medicine. Thank you so much, dear Dipti.
Thank you, Aloha. It's a pleasure to be here, and thank you to Eric. I'm really excited, and thank you to the Cardio Academic for inviting me. I wanted to talk today about ACC in the time of COVID. Obviously, the world is watching all of the developments with this COVID pandemic, and what is the American College of Cardiology doing? So I thought I would talk a little bit about what has been the response, what is the guidance for the cardiovascular team, and also about clinician wellness during this time of COVID. So I'll take my next slide. So as you know, the American College of Cardiology's vision is that it is a world where innovation and knowledge optimize cardiovascular care and outcomes. So really at the core of our vision is the fact that it is about the world, right? And so as you see here, the ACC has over 15,000 members that are outside of the United States. There are 42,000 international chapters, members in 139 countries. So this is great for us to be able to speak to our international members. And really at the core, we want to really see the world where innovation and knowledge optimize that cardiovascular care. So when the COVID pandemic hit, we really had to think about how do we reach all of our membership and how do we take care of our cardiovascular team members. So next slide. So we had a 4-prong approach for our response. So the first, as you see here, this was the ACC's COVID-19 response. One was a set of webinars. So we have done about multiple actually webinars. The initial one was with our Chinese colleagues to say what happened, you know, what was the early experience. One of the last webinars was one that Harlan Krumholz and I had. And we not only did we have a cardiologist from China, but we had a cardiologist from Italy. We had somebody from England. We had 2 cardiologists from New York, as well as one in Chicago. And Harlan Krumholz and I had a very nice discussion about what are we seeing with these COVID patients, how sick do they get, what are the cardiac issues that come up. So all of those webinars are on the ACC COVID Hub site. And, you know, we've had up to about 8 to 10,000 people on these webinars, and there have been multiple people that have accessed it afterwards. So number one, I want you to know that the webinars are available, that you can access those and you can go on and view those. because I think they're very, very helpful to know what the cardiac issues are. The second, I mentioned to you that this is all part of the COVID hub. And I want you to know that now, since this slide was made, we've had 1.2 million people that have visited the ACC COVID hub. And we've had at least, we get 10 to 15,000 people hitting that COVID hub on a daily basis. There have been multiple people that have downloaded the clinical bulletin, and there's multiple views to that COVID hub. So for those of you that have not seen the COVID hub, I really encourage you to do the COVID hub. I'm going to talk a little bit later on about the clinician wellness, but during this time, as the frontline as the frontline workers for illnesses like COVID, we really have to think about how does a clinician stay well. So the idea that we need to address clinician wellness was up there, and there are some webinars called Practice Made Perfect. There were also some self-care tips and some discussion on crisis communication, how to build resilience, how to cope under stressful conditions. And then lastly, there have been multiple JACC publications with regards to the COVID response. So next slide. So I wanted to go through and talk to you about what has been the COVID guidance for the cardiovascular team. Well, first of all, one of the things that we did was we took protocols that were developed by multiple cardiovascular societies in terms of diagnosing, triaging, isolation, and management of these patients that are cardiovascular patients. And so some of the societies were American Heart Association, the American Society of Echocardiography, the Heart Failure Society of America, Heart Rhythm Society, the Society of Cardiovascular Angiography and Interventions, and lastly, the Society of Cardiovascular Computed Tomography. Next slide. And so we took this partnership and developed guidelines for it. And again, those are available on the COVID hub. The other thing was to really educate our membership to say, hey, risk factors, particularly cardiovascular risk factors, were very important. So we know that patients that have cancer, patients that are immunocompromised, ones with cardiovascular disease and cardiovascular risk factors are increased risk, not only of acquiring COVID, but then to develop adverse outcomes. So if you have a patient that develops COVID and they have underlying cardiovascular disease, they tend to do worse. They have worse outcomes, more complications. So what are some of the comorbidities that you may see, that I may see, that are very common? Well, hypertension. Now, you don't typically think of hypertension as a huge cardiovascular risk factor, but it is. If in the COVID population, about 17.1% of the patients that we've been seeing have hypertension, and they don't do as well. Diabetics, about 10% of those patients are diabetic, and about 16% with cardiovascular or cerebrovascular disease. So this is data that came out of China that was published. And so what it did, it was bring to the forefront that we really need to be extra special careful with our patients that have cardiovascular risk factors, and know that the risk factors can cause more complications. And what are some of the complications? Well, they're listed here. The complications are things like arrhythmias, myocarditis is a big one. We see acute coronary syndrome. So you may see a COVID patient that comes and presents with acute coronary syndrome. The venous thromboembolism, we're learning more and more how common this is. And we're actually seeing that they have hypercoagulable states, and so they can develop pulmonary embolus. Cardiogenic shock, we've certainly seen that, and heart failure. So those are the common things that we're seeing in terms of cardiovascular complications with COVID. Next slide. So there's been some guidance with regards to medication. We strongly recommend guideline-directed medical therapy. I'll tell you, right before this webinar, I got a phone call from one of my patients who is an anesthesiologist, and he's a type 1 diabetic. He was told that he should discuss with me whether he should continue his angiotensin receptor blocker. And I told him, no, there's no data that he shouldn't take that. I said, we really feel strongly that he needs to continue his guideline-directed medical therapy. What about testing? We should only do the tests that have proven clinical benefit, and particularly in the time of COVID, we're very careful about making sure that we're doing the appropriate tests at the appropriate time. In terms of procedures, we want to make sure that if a patient is not sick, they have an elective procedure, that we postpone that till they have either symptoms or when it is safer for them as well as for us to be able to, because of the exposure. We just started to do some elective cases in our institution this week, and I will tell you that if the patient is having a TEE or if they're having a pacemaker, they're having to have a COVID test prior to the procedure. But if they're doing a cardioversion or an angiogram, other elective cases, and we're not doing them electively, cath patients have to have an indication. We're not necessarily doing a COVID test for them. There was also guidance about how to do telehealth. I can tell you that in our practice, we're doing about 70% telehealth. And we're doing that with a computer platform as well as a cell phone platform. So there has been some guidance that the ACC has provided with regards to that. So next slide. What about medications? There are lots of different medications. I already mentioned to you that some patients wanted to stop their ACE inhibitor or ARBs. What about statins? What about the RAS antagonist? What about the combination of hydrochloroquine and azithromycin? So there, you can go and get some guidance with regards to specific medication. There's actually a very good publication about talking about hydrochloroquine and azithromycin, particularly as it relates to the QT prolongation. As you know, here we're no longer able to give that combination of drug unless it's in the setting of a clinical trial. About 30% of the patients getting that combination get cardiotoxicity with the QT prolongation. So you have to be very, very careful. Next slide. The next slide talks about the different medications that have been tried. The first one listed there is a drug that has been used. It's an antiviral. Ribavirin is an antiviral that's been used for severe respiratory infections, hepatitis C. The next combination, lopinavir and ritonavir, those are drugs, Coletra, that are used for HIV. And so some of these drugs were initially used, some of them are no longer being used, but we did give some guidance with regards to dosing and adjustment of and medication interaction. Next slide. And pretty much the same thing on the next slide is that there's the hydrochloroquine, again, making sure that we know that there's QT prolongation. And some of these other drugs don't apply because we're not using them now. So next slide. Testing. When do you do a troponin? Well, I told you about 30% of COVID patients are presenting and are having troponin elevation. And if they do have a troponin elevation, they don't do as well. So we're saying that only do a troponin level if there's a diagnosis of acute MI or heart failure that's being considered. Otherwise, don't do it because you may see an abnormal troponin level, but it wouldn't necessarily be indicative of an MI or heart failure because because we're seeing some of that with the COVID patients. What about echocardiography or cardiac CT? When should you do that? There is some guidance. Again, with echocardiography, we're recommending echo only be performed if we think that it's going to provide some clinical benefit. And then same thing with CT angiograms, to do those when it's necessary. But again, there's some guidance along with the different societies making guidance. And so if you're interested, you can certainly find more on that COVID hub. Next slide. Again, this is more detailed about what are the elective indication for cardiac CT, what are the semi-urgent indications, and what are the urgent indications. So you see the urgent indication is acute chest pain, and patients that are presenting with chest pain that you may in the past have easily taken to the cath lab, you may consider doing a CT, easier, faster, less risk both to the patients and yourself. So remember again, because we have to consider the risk not only to the staff, but to the patients also. So we really need to be careful unless we know the patient is safe to have some of these procedures. Next slide. Echocardiography. It's interesting, a lot of questions in the beginning about when should you do an echo? And if there is an echo, what should we consider? Well, I think if you're doing a regular transthoracic echo, as long as you're wearing gloves and a mask, I think it's safe. But in terms of TEEs, because of the airborne protection, we've been very, very careful with those. And now, in fact, we're making sure that those patients are having their COVID test done prior to doing a TEE. So next slide. And again, these recommendations have been made together with the American Society of Echocardiography. And there's actually a statement of protection of patients and echocardiography service providers. So, and it talks about who, what, when should you have personal protective wear, how do you limit the exposure, how should the room be. So these are very good suggestions to look at prior to you sort of initiating some of this in your own practice. Next slide. What about procedures, cardiac cath, EP studies? What about structural heart disease interventions? Well, again, the Society of Cardiac Angiography and Intervention initially put out a guidance that ACC adopted. And initially we were saying that if somebody did present with a STEMI, that you could consider thrombolytic if they were stable. If they were high-risk STEMI patients, you still took them to the cath lab. And so there were definitely guidance with regards to this. I can tell you we didn't do very many elective procedures. We're still not doing elective procedures. We're doing more patients that are high risk that need to have angiograms done. Next slide. Same thing with our EP colleagues. We think that EP procedures for urgent, semi-urgent, and non-urgent, again, they've divided it up into these categories. And when should you have a catheter ablation? Well, if somebody has VT for medically refractory electric storm, of course, you're going to do that. But if you think that the patient needs a PVC ablation or AFib ablation in a stable patient, those are considered non-urgent elective. And again, there's discussion about what PPE should you have for EP procedures, and also making sure that if the patient is positive for COVID, that you make sure you have a PAPR on or an N95 mask, that there's protective eyewear. So again, remember, everything is about how to minimize the risk to you, the cardiovascular team members, as well as the patient. Next slide. Again, more of the breakdown of when should the patients be seen in the hospital versus outside outpatient clinic. We don't have time to go into all of this, but I think the issue is to try to make sure that it's safe for both ends, for the patient as well as the staff. Next slide. Can I have the next slide? Aloha, can we have the next slide?
Aloha.
We may have lost the connection there. That's what I'm thinking. Yeah. So, but I can tell you that, so besides talking about all of the different procedures, I think that we've really provided some good guidance on that. I don't know how much of this is stuff that you guys have put in place, but I would, is there a way that somebody else can take and do the next slide?
Yeah, I will do it. Hold on.
Okay. Yeah, I'd love into question and answer period for you guys to ask specific questions, because this is more of an overview, but I think the goal in a COVID time is to really say, how do you take care of it? So this was the structural heart interventions. So again, we were not doing any TAVRs during this time. I think we did one TAVR. We did somebody that was very, very sick with heart failure and had critical AS. But I think we were really trying to minimize it. What we did was to have an actual protocol of how to sort out the patients that really needed a TAVR or the ones that needed a mitral clip. And they really came out with a protocol to say who we do. So again, these elective indications, semi-urgent and urgent. And obviously the urgent indication would be somebody with symptomatic or severe AS. Next slide. So the telehealth was the last thing. And I told you that we're doing telehealth using not only a computer platform, but also what I found personally was that the cell phone was really easy. What we do is we send out a text message, and the patient, so when we dial their number, it sends a text message to them saying that we're waiting on the line. and then the patient just clicks, says that it's okay. They accept this, so it's HIPAA compliant, and then they come up and we're able to have a chat. So today I did one of those telehealth, and the patient was actually in the car, pulled over, and we had a nice chat, and then we were able to do it. So I think the telehealth is here to stay. I think that this was something that they had really wanted, but I think the COVID era has really unmasked it. But the recommendation for how to go about creating a telehealth or digital health program, some of that is on that COVID hub. Next slide. So I kind of wanted to switch gears, and so this is just some references if somebody wanted to actually look up some of the articles of some of the things that I referenced. And next slide. I thought I would put that in there just for yours. Okay, so I wanted to switch gears and really talk to you about clinician well-being, because as healthcare providers and clinicians, I mean, we're at the front line. We're seeing these patients that, I mean, when particularly in New York and in some of the states where they've had been hit, the clinicians have experienced a lot of stress during this time. So we were very aware of it. And as you know, the college has been at the forefront of making sure that we address this issue of clinician well-being. You know, there's been studies done, multiple studies over the last several years that show that physicians have been, you can stay on that slide, go to the next slide, that the physicians have had a high rate of burnout. Almost 50% of physicians report some level of burnout. So the ACC has actually convened a group for clinician well-being and said, we need to address this. And so this has been part of the strategic plan. So on the website, one of the things they talk about is crisis communication for the cardiovascular team member. And so this came actually as work of this guy named Victor Covello. And Dr. Covello, I had invited Dr. Covello to come to the ACC about 6 years ago. And he talked to us about at the times of crisis, and I would say that COVID has been a crisis. How do you communicate to people? How do you communicate to your patients? How do you communicate to the team members? How do you communicate with each other? So that's called crisis communication. So he gave us some really, really good tips. And he was talking about what are the trust factors in a high stress situation. And he says that in the first 9 to 30 seconds, patients listen and they look for empathy and compassion. And 50% of the trust is built up in that first 30 seconds. So it's very important that you initiate any conversation with empathy and compassion. And then you focus on what you want to communicate first as well as last. And repeat it, because if you adhere to the primacy and recency principle, what he says, what Dr. Covello says, is the information presented at the beginning and at the end of communication tends to be retained more effectively than information presented in the middle. So it means that start with empathy, get your message, talk about other things, and then close again with the same message that you started with. And really limit the key messages to 3 to 5, using as few words as possible. And so anyway, I think this is really a very, very good messaging. The crisis communication is very key. There was information on that. Next slide. When you talk about clinician wellness, there's a lot of discussion about resilience. How do you develop resilience in the times of crisis? And so there are 6 domains of resilience. And so the website talks about that more in detail. There's also tips on stress management, how to recognize your stress, how to steady yourself, seek yourself, and do relaxation techniques. Next slide. And then tips with really coping with the COVID-19 stressor. Remember self-care, your body matters, rest, stay updated, keep up with all that knowledge base that's important. Don't listen too much to the news, unplug from the noise. Give yourself a brain break, practice compassion, stay connected, make sure you take care of your family, your friends, and really honor everybody's work, because this is an important time. Next slide. So the American Psychiatric Association president describes trauma being experienced by healthcare workers on the front line. And he said that in the center of the epidemic, it is really a very horrendous experience that no one could possibly be prepared for. And he said that that really you have to think that patients, that healthcare workers are really experiencing some trauma. Next slide. And I'm just closing. I have one or two more slides because I want to give you some time to answer questions. I think we have one or two more slides. Okay, well, I think the next slide was really just to build on this thing about trauma. There was a ER physician in New York who was in her 40s that committed suicide last week, and it was in the news. And there was also a EMT that committed suicide. So one of the things from the American Psychiatric Association is that be prepared for our frontline workers to develop depression, suicide, and that you really, really need to attend to the clinician wellness, particularly at this time. So I think that I want to stop here. It was more, I was just addressing these issues of clinician wellness, and I'm saying stay current, but also make sure that at the end of it, not only for yourself, but the whole cardiovascular team, make sure that you're paying attention to the wellness piece. So I'll stop here. Thank you very much, and I'll be happy to take some questions.
Thank you, Dipti. Thank you very much for your lecture. We have received several questions here.
Okay.
I think this is a terrible experience we are now living, not expected before, to talk about the COVID. What do you think, what are your personal expectations about the way to be cardiology after COVID?
About cardiology?
Yes.
Well, I think that we are going to, first of all, I think that we are definitely going to see this movement to telehealth. I think we're going to have a hybrid model. I think we're not just going to see patients in our office. We're going to do telehealth. Interestingly, I think we're going to have telemonitoring and teleteaching in our cath labs. So when you have these new procedures that are coming out, I think that we're going to get proctors that will be somewhere else, that will be proctoring us on big screens and stuff like that. So I do think that one of the things that's come out of this is the idea of telehealthing and remote exchange of information. I mean, even what we're doing today is an exchange of information, right? So I do think that this issue of being remote and how to exchange information. I think the other thing that's really come out of COVID is that the international community, at least in terms of cardiovascular medicine, has really come together, and we're sharing information. We're talking like we are today. We're learning from each other. We're saying important things like we need the clinical trials. So I think that from going forward, the international community has come together in an incredible way, because now we realize we can Zoom, we can use different platforms to really talk to each other much faster than we ever have. So I do think those are going to be the big changes.
Okay. What about education? Education for fellows in the hospitals, because now they are busy resolving other problems, not the real problems they need to resolve or they need to learn in their specialties. But what do you think is going to be the future? And also, because American College of Cardiology is a very strong education society, how do you think will be the things in the near future? How do you think the education way to teach cardiology will going to be around the world?
Well, I mean, I think that there's going to be more collaboration internationally. So I think education is going to be a mix between class. You know, it's not just going to be all classroom now. There's going to be this this remote learning experience that we've been gaining recently. So I think we're going to do that. Can you imagine if, say, somebody that's an expert in a new up-and-coming procedure, if we could just zoom into the cath lab, for example, when they're doing a procedure, and if you're a fellow to learn from that person and be able to watch, I mean, that's pretty amazing. So I think we're going to see that. So it won't matter where you are in the world, you're going to be able to get some of that education faster, and look up the things that you want. I think this idea of archiving webinars so you could watch it when you have the time to do it, rather than when you don't have the time. I mean, as fellows, we didn't always have time to be able to take the time away to learn. But guess what? Now you could be sitting at home that night and do it. Think about what happened this year with ACC, with the virtual ACC. Look at how many people logged on from all over the world. We had an incredible number of people logging in. I think that's what education is going to be about.
Okay.
Perfect. Yes, I think that's very important because I think all the fellows are very worried about what's going to happen with this year of education. So I think that's a big worry for everyone, and I think it's all around the world. But as you say, I think it's a big effort, but from everyone. So I think here the fellows will have to take a lot of responsibility about their own education. That's going to be very important.
Right. And I think that there's so many opportunities now because there's so many, like if I were a fellow right now in cardiology, I would be on that COVID hub. I would watch every one of those webinars. There's so much information of things that you can learn. And you're not learning it from one person. You've got an international cast talking about things that they're actually seeing. I mean, how better of a teacher can you get than that? So I do think you're right. The fellows are going to have to be more creative and say that they're going to be able to grab the experiences that they want. You know, in any crisis, there are opportunities. So you just have to look for those opportunities and seize those. But education is always going to be there for the people that want to be educated.
Exactly. I think we just have the time for the lecture. We would like to thank you, Dipti, for your presentation, also for your friendship, and also for the opportunity to collaborate with us in this important webinar. We are presenting of our fellows, our cardiologists, internal medicine people. I think it's a very good opportunity to learn about the new things about cardiac imaging during all this month. We really appreciate your participation.
Yeah. Thank you thank you for having me. I appreciate it. And I wish
you
all good health.
Thank you so much.
Be
Take
safe.
care.
Stay safe.
Yes.
Thank you.
Thank you. See you soon. Bye-bye.
Bye-bye.
Thank you. Muy bien, agradecemos a la doctora Dipti Chaporia, vicepresidente de la American College of Cardiology, de haber estado con nosotros. El American College of Cardiology en los últimos 5 años o 6 tendrá 3 mujeres como presidentas. Una, de hecho, actualmente lo es. Ella será la próxima. Y recientemente tuvimos a Mary Walsh, que fue presidenta. O sea que eso habla muy bien de la fortaleza de las cardiólogas trabajando en los Estados Unidos para la educación global. Nos complace ahora presentar a nuestro siguiente invitado. Nuestro siguiente invitado es el doctor Marcelo Hartel. Él es un médico cardiólogo, clínico y en investigación, especialista en imagen, particularmente eco. Es del Instituto de Cardiología de Río Grande do Sul. Va a hacernos favor de participar con nosotros, hablando de un tema también que es muy interesante, sobre todo ahora que no queremos tener contactos cercanos con estos pacientes que pueden estar en riesgo o que tienen establecida la enfermedad COVID, y va a hablarnos sobre el ultrasonido pulmonar y cardíaco en pacientes que tienen COVID. Marcelo, bienvenido. No sé si vas a hacer tu presentación en español o en inglés, pero bueno, te seguiremos en los próximos minutos. Gracias por participar con nosotros desde Brasil. Bienvenido a este webinar.
Gracias, Eric. Thank you very much to be again in Cardio Academic with great pleasure. Good evening for all. So when we talk about COVID, we need to know that most of the patients have a pulmonary and cardiac involvement. And when we evaluate these patients, we should minimize the risk of exposure from all the physicians and all the healthcare professionals. So we need to balance between the clinical benefit for the patient to have an additive imaging examination and the waste of personal protection equipment, the thin exposure, and the contamination of the ultrasound machine. About the imaging evaluation of these patients, most of the patients have a normal chest X-ray. So this is not a good exam to screen for pulmonary involvement. Most of these alterations in chest X-ray just appear between 10 and 12 days from the symptom onset. So it's a very, very late finding, and it's not useful for screening patients and stratify the risk of these patients. The CT is the most accurate method for assessing the pulmonary involvement, but we have to transport the patient to the radiology department. So it is very difficult to use this methodology in ER setting. Also, we have the contamination risk from all the team during the transportation from all the environments of the hospital. It uses ionizing radiation. It's too costly, so it's impossible to perform several evaluations, meaning in critical care patients when the transportation could put in risk the patient. So that's why focused lung and cardiovascular ultrasound is very useful in this setting. Because lung ultrasound have a high sensitivity to detecting pleural and parenchymal changes. It's ionization radiation free. It could be performed at the bedside and is very useful for evaluation and monitoring the patient. So we could perform serial assessments to ensure if the treatment is appropriate and the patient is having a benefit from all the managements. When we revise the last recommendations from ESCVI and the American Society of Echo, we could ensure that they talk a lot about the appropriate use of cardiovascular imaging. And they state that you just should use echocardiography or advanced methodologies if they will substantially change the patient management or be life-saving. And due to the risk of widespread contamination due to transportation and also the thin exposure, they recommend to use focused cardiovascular ultrasound and also lung ultrasound with reduced duration of examination to reduce the exposure. And the same is stated by the American Society of Echo. So this is the main examination in our COVID patients. And of course, when you talk about focused ultrasound and focused ultrasound in COVID patients, we need to be straight to when we use this methodology. Go directly to answer the clinical question. So using concrete clinical situations and have a concrete clinical question to apply and answer to minimize the exposure. And of course, we need to be cautious because we have just a few evidence in literature about the use of focused ultrasound, lung mainly, in COVID-19 patients. We have more case reports and case series, but in the last days, start to appear more and more evidence and new papers demonstrate the clinical benefits. My lesson will focus about lung ultrasound, how to do it and how to interpret the main sonographic finds, what finds are typical from COVID-19 patients, and then I will talk about focused cardiovascular ultrasound. So, back into the beginning, during several times, we stated that lung ultrasound would not be useful for evaluating the lung and the parenchyma of the lung. Why? Because when we place the probe in the anterior chest, the ultrasound energy are dissipated, and we do not have a clear formation of image. So this statement was true. But since in 1960s and 1980s, we start to have some reports in literature that describe some artifacts found in different pathological situations. So to understand lung ultrasound, we need to first of all understand how the basic image and the normal image is created. So looking to the thoracic wall, we can have a first layer of skin and soft tissue, then a second layer of muscle and the ribs, then a pleural line, and then the lung. And this is what we will see in this image that at the first impression, it's not properly a clear image. Looking more closely, we can see that we have the first layer of the subcutaneous with the soft tissue and the muscles and the ribs. And how we see under this first layer is artifacts. And this is the main place that we will look for pulmonary alterations. The first artifacts are caused by the ribs. So we have the shadowing of the ribs. We have the pleural line that is a high echogenic line, which is formed by the reflection of the lung, the ultrasound energy. And then you have the artifact that is the several parallel lines to the pleural line that was named the A lines. So this is the image of a normal lung when you look using ultrasound. I would ask you all to fix this image because it's the reference for all the other situations linked to the pathology and the COVID-19 pulmonary pathological finds. And we need to look that you have here image that is named the lungs line, that is the movement of the pleural line due to the respiration. So when we started to look this image, we could find different patterns. And the first pattern, in the classic one, was firstly named as comet tail artifact. What is that? Different from the normal, the aerated lung, the normal lung, when we place the probe in the anterior thoracic wall, this energy will reverberate between the thickened interalveolar septums due to the accumulation of extravascular lung water, or simply by fibrosis or other pathological accommitments. And what we will see are several lines starting at the pleural line and going to the lower part of the imaging without shadowing and moving with the respiration. And the most interesting thing in the first report is that as more extravascular lung water we have in these patients, more B lines we have. So it is a semi-quantitative way to assess the amount of extravascular lung water and the pulmonary congestion. So the normal lung, we can say that's black, the aerated lung. When we start to have deaeration, extravascular lung water, this lung start to be black and white due to the several B lines. In acute pulmonary edema, when we have a great amount of extravascular lung water, interstitial and alveolar edema, we have a white lung. And the most deaerated lung will be in a consolidation when we have simply the image, the real image of the parenchyma. So this is the only situation that we could see the lung parenchyma through the lung ultrasound. So here we can see this image of B lines. We can see that they are very dynamic and they move according to the respiration movements. This imaging we all should again keep in mind. Okay, so another image that we should keep in mind is the lung consolidation. We have the completely deaeration of the lung, and we have a similar image to the spleen, or and you can look inside the parenchyma, these very bright areas. There are encapsulated air, and you could also see the ultrasound bronchograms that are the draw of the bronchus, which inside of them have a deposit of secretion. So to do lung ultrasound, what we need? We need just basic technology. We can take any ultrasound machine. We just need bidimensional imaging. It's not necessary to have Doppler, and it's not necessary to have a harmonic image. And what type of equipment? All, from the conventional to the portable ones. Right now, the most recommended ones are the pocket or the portable, because they are very easy to disinfection, and they are easy to carry inside and outside from the room or ICU that you are examination a COVID-19 patients. And what type of probe to use? We can use the linear probe. This is very useful to image the pleura line and to see if you have thickness of the pleura, irregularities of the pleura, or subpleural consolidations. Here you can see normal lung imaging using the linear probe. You can see the pleural line, the lung sliding, A lines parallel to the pleural line. We can see the muscle, the ribs, and the soft tissue. We can use also the broadband phased array. I can say that is the most used probe to perform lung ultrasound, because we can just do this examination following an echocardiography examination or a focused cardiovascular ultrasound. This is very good to see the B lines, deep consolidations, and pleural effusion. It's not so useful to see the pleural thickness or irregularities. And another probe very used is the curved array one. I personally do not like, because it has a large footprint, so it's very difficult to put in between the costal ribs, the costal arcs, and but it's the most used for the intensive care and emergency professionals. After that, we need to select the preset. If possible, if your machine have that, we should also always select the lung preset. If it does not have, we could select the abdomen preset, or at least the cardiac preset. Again, we should optimize to see the pleural line, not over again, because then it will be very difficult to see the B lines and also the pulmonary consolidation. The deep, around 8 to 10 centimeters deep. And where to scan? Using the critical care protocols, we do not have studies about the COVID patients. We should divide the anterior thorax in 4 areas to each hemithorax. So anterior, a superior, and inferior, and then at the back, more 4 areas, superiors and inferior areas. But when we start to practice and to learn more and more in COVID-19 patients, we could ensure that it's very necessary to scan out the thorax, not these areas, only these areas, because the finds are spread around the thorax, and we need to search and spend the time looking for it to perform the diagnosis. And what we should look for in COVID-19 patients. Pleural effusion is very hard. So when we find that, we could almost rule out the possibility of COVID-19 infection. We could think about in cardiogenic dyspnea, complicated pneumonia, or other diagnoses. The most common finding are pleural thickening or irregular pleura. It's a very, very early finding. Then we can find B-lines in a curtain or B-lines with sparred areas. Why? Because when you look at CT scan from this patient, we can find that at the beginning, that early stages, the pulmonary commitment are very spared. So we can find the B-lines with a normal lung nearby. And then with more advanced disease, we have subpleural consolidations and large consolidations. Here in these images, the first image, we can see a thickened pleural line with some irregularities and a B-line in curtain. In the image below, we can find B-lines with sparred areas and a normal pleural line. And here in this image, if you pay attention at the pleural line, we find a portion that have a subpleural consolidation. This is a finding in more advanced disease. So let's review it. In early stages, correlated with CT images, in these patients, usually we find a thickened interlobular or interalveolar septums and a thickened pleura. In lung ultrasound images, we could find these irregularities in pleura, also the thickened pleura, and some B-lines. In an intermediated stage, when we found ground glass opacifications at the CT, so we have a commitment of the parenchyma. On lung ultrasound image, we have B-lines like a curtain. And here we can see irregularities of the pleura and also a subpleural consolidation in this part. In severe stage, then we have more parenchymal commitment. We have consolidations, and we find also these consolidations in ultrasound imagings. We here find a huge subpleural consolidation. And note that we used the linear probe to look better to the pleura. And in extreme stages, these patients could have extended consolidations. Here we have a hepatized lung. We can find the dynamic ultrasound bronchograms. We can see these bright spots moving. This is air encapsulated into the bronchus. This use most of the times are linked to other infections that this patient develop. And putting side by side the images, at the left we can see a normal lung. The first image that I asked you all to keep in mind, we can see the soft tissues then a bright pleural line with the lung sliding, and the parallel A lines. The image at the center, we can see a thickened pleura with some irregularities and some B lines. And the right image, we can see a B-line curtain, thickened pleura with irregularities, and a subpleural consolidation. And here, a huge subpleural consolidation. And this right image, we can see a small, a tiny pleural effusion, just to remember that this is not a common find, it's a hard finding in COVID-19 patients, so it mostly rule out the suspicion of COVID. To understand better and to stratify this patient, they propose some scores for each area of the thorax that we scan. We look for these finds, and if we find at least 3 B lines or convalescent B lines taking less than 50% of the skin, we will give 1 point. And if you have subpleural involvement, then we will add the letter P. If we find convalescent B line taking more than 50% of the skin, so in 14, we will give 2 points. And if you have a pleural involvement, we will also give the letter P. And if you find consolidations, this will give it 3 points. And then for each of these areas, we will note the number of points, and the sum of these areas will be the total score. This is very useful to follow up the patient and not if he is getting better or the pulmonary involvement are getting worse. And also we need to note the number of areas with subpleural involvement. And the qualitative description is very important, so we need to describe the type of the consolidation and the extension. Why? Because they have classified these patients according to the CT finds in 2 types. One type, we have a higher relation PaO2, FeO2, and the H type, we have a low relation. And this is very linked with the finds of the lung ultrasound. So in our institution, we established this protocol. We have a tip with the findings, the most common finds in lung ultrasound. For everyone who performs the focused lung ultrasound, take a note, and then we can have the fast report to compare between the following evaluations. Okay, and about the focus of the cardiovascular ultrasound, when we should do it? Following a lung ultrasound, if we are doing a lung ultrasound, we just follow with a cardiovascular examination, or if this patient have EKG alteration or enzyme alterations or something that could raise attention from cardiac involvement or myocarditis. You take some views. The subcostal view is the first one because it's most easy to do, and you can have a panoramic view of the 4 chambers and also assess the volemic state of this patient. Then we could look a long axis view, a personal long axis view, to assess the left ventricle function and some valvular abnormalities. Then we could perform a short axis view, and at the end, an apical 4-chamber view to look also the right ventricle. And what we should note. Left ventricle, qualitative analysis of the size, the global and the regional function. Why? Because it's linked to myocarditis and cardiomyopathies, shock, cardiogenic shock, and acute coronary syndromes. The right ventricle, we should assess mainly the volume overload or pressure overload, and also look for repercussion of a pericardial effusion. For the pericardium, you should note if this patient have some hemodynamic compromise or not, and the valves are gross regurgitation or stenosis. So here we have two examples. On the left image, we can see a severe systolic dysfunction. We have a diffuse hypokinesia with a very mild pericardial effusion. At the right image, we can see pressure overload on the right ventricular chamber with this D shape of the interventricular septum. And here we can see an image from a patient that developed the myocarditis. We can see akinesia from the midi-apical segments. So it gives the impression of a takotsubo. It's quite similar. And the subcostal image, we can see again the dysfunction of the left ventricle chamber, the severe systolic dysfunction. This patient received treatment for myocarditis. He is immunosuppressed with steroids, and he developed very well and recovered from the cardiovascular function. So the final message, first of all, we should protect ourselves, so minimize our exposure. So just do the examination if you be very useful for the management of the patient. About the focused lung ultrasound, we need more evidence from the literature, but papers are being published in the last days. We are also developing a research to assess the prognostic value. About the diagnosis, it is more sensitive than chest X-ray, and several studies, a series of cases shows that it's quite similar to CT finds, and probably it's very useful for monitoring mild cases and also for the screen, because we can find the pulmonary alterations in lung ultrasound before the patient gets symptomatic. This is quite important. It's very useful for his certification and prognosis, high negative predictive value, and also for monitoring these patients. And about the focused cardiovascular ultrasound, we should pay attention for left ventricle systolic function, right ventricle overload, and pericardial effusion. That is the most common findings. Thank you very much.
Muchas gracias, Marcelo, te quisiéramos felicitar por tu excelente plática, muy bien ilustrada, muy didáctica, muy fácil de entender. Hablo en español porque sé que me puedes seguir muy bien.
Sí, hablo un poquito.
Te agradecemos muchísimo la presentación. Estamos, aquí ya te podemos ver a ti, estamos ya sobre el tiempo del programa. Hemos recibido muchas preguntas, aquí los tenemos en el chat. Nos gustaría muchísimo son tantas preguntas que no nos da tiempo contestarlas. Lo que le vamos a llegar es las preguntas para que nos puedas dar la respuesta y nosotros la podamos publicar en el website para que las personas que han preguntado, son muchísimas preguntas de muchos aspectos, creo que son preguntas muy interesantes, pero perderíamos media hora más en poderlas contestar. Las vamos a tratar de resumir por áreas, te las hacemos llegar. Si nos puedes dar la respuesta y las tendremos listas en el website de Cardio Academic la semana que entra para que las personas puedan contestarlas.
Sí,
no sé
perfecto.
si quisieras dar
Muy
un...
bien. Sí. Eso está muy bien.
Un mensaje final a nuestros médicos conectados, ¿cómo están haciendo este procedimiento? Algunas palabras final antes de cerrar esta primera sesión, que la verdad ha sido excelente con Dipti y contigo participando. Creo que nos ha dejado mucha enseñanza a ambos y creo que vamos calentando motores para que este webinar sea muy interesante a lo largo del mes.
Sí, sí. Muy bien. So, right now, we have some professionals at my institution. We are using to screen patients at the emergency department. It's quite interesting because we are finding very useful information to monitor this mild case and then have be more secure to release the patient and say, okay, you can go home and then you observe your case because you do not have a higher compromise of the lung. We have just a few findings that are from the beginning stages. So this is, I think, is the main use of the lung ultrasound right now in our hospital, because we do not have access for CT for all patients. It's very difficult to use, and also because we could spread the infection. And the second most important use is inside the intensive care unit. So when the patient arrives to the intensive care unit, we perform a focused lung and cardiovascular ultrasound to first stratify this patient and then have information to follow up. We are not doing it day by day. We do just if you have some clinical deterioration or changing ventilatory parameters or hemodynamic parameters. And before this patient leave the ICU, we also do again the lung ultrasound and cardiac ultrasound. This is our protocol.
Okay, thank you.
Muy bien, Marcelo, muchas gracias. Esta fue una presentación espectacular y bueno, nos demuestra justo lo que hemos visto, que en estos pacientes es muy complicado el moverlos a tomografía, a otro método de imagen y definitivamente el ultrasonido aquí juega un papel muy, muy importante y nos lo acabas de demostrar. Muchísimas gracias. Gracias, Marcelo. Y bueno, entonces queremos llegar a estas preguntas y bueno, pues hemos llegado al final de esta sesión. Queremos agradecer a todos los que participaron porque participaron de muchos sitios. Agradecemos que participaron de Guatemala, de Colombia, de Perú, participaron de Argentina, de Brasil, de Estados Unidos. Entonces creo que este fue un excelente ejercicio y va a ser muy exitoso para todos. Y lo más importante es todo lo que nos dejó aquí. Me gustaría comentar acerca de la presentación de Dipti. Creo que el punto clave en este momento es el que nos tratemos todos con empatía. Creo esto es muy enriquecedor de la presentación de Dipti, la vicepresidenta del ACC. Es un momento de tratarnos con empatía y justamente qué mejor que hacerlo en la academia y el poder participar todos juntos de esta enseñanza y fue maravilloso el que Latinoamérica se haya unido a esta sesión. Te agradecemos muchísimo, Marcelo, tu participación.
Muchas gracias por la invitación.
Gracias. Y para muchas personas que nos preguntan que les gustaron mucho las dos pláticas de hoy y que les gustaría volverlas a escuchar, mencioné al principio que todas estas pláticas están siendo grabadas previa autorización de los profesores y las tendremos listas en el web de Cardio Academy para que las vuelvan a escuchar en otro momento con más calma y compartirla inclusive con algunas otras personas, alumnos, etcétera, para expandir el conocimiento que se logrará en este mes de trabajo que tendremos todos juntos. Una vez más, muchas gracias, Marcelo.
Doctor,
y nos vemos.
Eric, la encuesta
Gracias.
se las acabo de poner, Eric y Aloha, nada más para que nos ayuden ahí a contestarla, ¿no?
Perfecto, se acaba de subir una encuesta, si nos pudieran ayudar a hacer la encuesta, que esto nos va a ayudar muchísimo justamente para evaluar cómo estuvo todo, cómo lo hicimos. Y bueno, y queremos agradecer en particular a Marco Antonio González, que es un gran amigo nuestro y bueno, agradecemos todo su apoyo, es nuestro amigo de IPADE y agradecemos todo su apoyo para el que hayamos podido realizar esta sesión. Muchísimas gracias, Marco, por tu apoyo.
No, hombre, con mucho gusto. Ya aprendimos de cardiología.
También muchas gracias. Sí, Marco, ha sido importantísimo tu apoyo tecnológico para todos. Y trataremos de cada vez irlo haciendo mejor, y creo que pues ha sido un buen inicio para lo que nos espera durante todo el mes, así que esperamos que nos sigan, y no solo que nos sigan los que hoy se conectaron, sino que podamos tener aún más conectados. Tuvimos más de 400, 500 personas conectadas, lo cual creo que es un buen número para haber comenzado, así que los esperamos el próximo jueves, en el que hablaremos de Ischemia Trial, con otro amigo brasileño de Sao Paulo, que hablará de la parte de imagen del Ischemia Trial, y el doctor Hadley Wilson, que es miembro del Board of Trustees del American College of Cardiology, que hablará de la parte intervencionista de isquemia. Creo que siempre ha habido mucha controversia entre la parte clínica, médica, imagenológica y la parte intervencionista en la cardiopatía isquémica, y creo que aquí será un muy buen debate para el próximo jueves, así que los esperamos a las 16 horas de México. Muchas gracias a todos y nos vemos el próximo jueves. Saludos.
Gracias. Be safe, everyone.
Saludos. Bye. Bye.